So in my previous video I will talk about up to this level. So 5 to 10% excretion of bilirubin in the stool in the form of stercobilin and the urine in the form of urobilinogen. So 5 to 10% excretion. So 90 to 95% again reabsorb at the terminal ileum and also absorb in the enterohepatic circulation. So this is how, what's the normal physiology, how the bilirubin metabolism happen, in which organ play an important role. So RBC breakdown, they convert into heme, bilirubin, and in the liver. So this is a main track, main home for the conjugation of bilirubin. If liver is not working very well, so this unconjugated will not be conjugated. So unconjugated raise in the blood, so and they give sign and symptom. But if pathology in the liver, this is if pathology present here like in the blood, we call prehepatic jaundice like hemolysis or sickle cell anemia. I will go into detail later. And if pathology is present in the liver like hepatitis, so conjugation happen, but conjugation happen, some conjugation happen but more not happen, so they again go back in the blood. So unconjugated and conjugated both are waste, because problem is what? Problem that liver cell inflame and they will not take enough unconjugated bilirubin. But in the post hepatic jaundice, unconjugated both are waste, because problem in not in the liver, problem in the drainage system. So now I will talk about the basic anatomy of biliary system, because to know this is very important. So this is the right hepatic duct, this is the left hepatic duct, and this is a common hepatic duct. Then there is a gallbladder, and this is a cystic duct and common bile duct, and this is a pancreatic duct. So common bile duct and pancreatic duct, they make a hepatopancreatic ampulla of water. So this is a dilated part which is formed by the common bile duct and pancreatic duct. This is a very good diagram, by the way. So this is a gallbladder, this is a fundus, and this is a body, and this is the infundibulum, or we call Hartmann pouch of gallbladder, and this is the neck of gallbladder. If any stone which stuck in the cystic duct or neck of gallbladder, they cause cholecystitis, and this is also a cause of post-hepatic jaundice or obstructive jaundice. This is a right hepatic duct, this is a left hepatic duct, and this is a common hepatic duct. And common bile duct and pancreatic duct, they drain into what? They make what? Ampulla of water, and that ampulla of water drain into a duodenum and major papilla of water. If any stone which obstruct here, any pathology, any cancer like head of pancreatic cancer which obstruct the pancreatic duct, any stone which obstruct the common bile duct, or any stone which obstruct the cystic duct, or any stone or any pathology which cause stenosis of common hepatic duct, they all lead to what? Post-hepatic jaundice, or you can call obstructive jaundice. That problem is not in the conjugation, problem will be in the drainage system. Drainage system will not properly work. Why? Because obstruction is outside the liver. So I hope so you will understand very well. Now I will talk about one by one that what is a prehepatic jaundice. Actually prehepatic jaundice is that problem present before the liver. Maybe problem it is caused by hemolysis going on, or conjugated problem in which hyperbilirubinemia will be happen, like in Gilbert syndrome. So hemolysis, like in which condition hemolysis happen, like sickle cell anemia in which RBC shape is not very well, and autoimmune destruction of RBC, or in Gilbert syndrome like decreased glucuronide transferase activity, because that enzyme which conjugate the bilirubin first, which unconjugated bilirubin converted into conjugated bilirubin, so through the help of this enzyme, so bilirubin intake will be reduced, as I will talk in that video, that picture, that bilirubin converting to unconjugated bilirubin is converted to conjugated bilirubin. Okay, so up to now I hope so you understand. So in my next video I will talk about further